like the cameras into that system. Yeah, so it means we can have the audio from the microphone straight to the studio, and then also the same with the curtain air. And this will be like how many gigabytes is delayed as much. What do you run?
No, I haven't actually really done it. My husband's been
Oh, yeah.
and I feel really bad because
You delay 1.2. Yeah. Oh, really?
Yeah. Okay, great. Well, if you can't do anything, I'll give you a call.
Yeah, yeah, totally. But yeah, it's all good, especially if, only listening to on radio and you're not even aware. Yeah,
I feel like we might just
something about
Yeah.
Well, kia ora koutou katoa, no mai haere mai, ki te manatu hauora. Thanks very much for coming up again for today's update. And today I'm joined virtually from Australia by Professor Peter McIntyre. He is the medical advisor to IMAC, the Immunisation Advisory Centre, and he's from the University Department of Women's and Children's Health at the University of Otago. He's going to specifically talk with an update around vaccination in children with the latest evidence. So just on today's numbers, today we're reporting 15,250 new community cases of COVID-19. There are 830 people in hospital, and 26 of those are in intensive care or high dependency units. Sadly, today we're also reporting an additional 22 people who have died with COVID-19, and that takes the total number of publicly reported deaths to 338, and the 7-day rolling average to 17. I do want to pass on, as we do each day, our sincere condolences to families and whānau of people who have passed. Now, number of deaths in New Zealand linked to COVID-19 is rising, sadly, and as we expected with the outbreak. Our total number of deaths per million people now is 59. It's important, though, to point out that even with that increase, New Zealand still has by far the lowest cumulative death rate from COVID-19 of any OECD country, and one of the lowest in the world. There was a comparison made a day or two back about our death rate compared with the USA. In my mind, that's like comparing pears with beefsteaks, actually. If you look back at the various outbreaks that the US has had, including their Omicron outbreak most recently, the death rate so far in our Omicron outbreak, and we are now 3 months into it, the death rate here is a fifth of what it was at the peak of the US Omicron outbreak. They are clearly at a different point in their Omicron outbreak. Hospitalisations are declining, particularly in the northern region, as is evident again in the last day or two. Just looking at our outbreak across the Motu, there's a different pattern we're seeing in the main metropolitan centres compared with the regions. You will have noticed that in Auckland and also in Capital Coast and Hutt Valley District Health Boards, which are really just confined to the cities in those regions, that the outbreak went up quite quickly, peaked, and then is coming down quite quickly. We're seeing a different pattern out in the regions where the outbreak develops more slowly and there is a more sustained peak. Good examples of this are in the Waikato and also our Southern District Health Board, which covers not just Dunedin but the Otago and Southland areas. Interestingly too, we've seen a pattern of generally lower hospitalisation rates out in the regions. So if I take Tairāwhiti, for example, over the last 2 weeks it's had the highest case rate in the country, but has only ever had just a handful of hospitalisations and just 1 or 2 a day in the last day or so. COVID-19 treatments update. Minister Little, Health Minister Little provided an update on that this morning, that we now have available from next week the first oral antiviral, Paxlovid, which is our first consignment of which has arrived in the country and will be available to be prescribed in primary care next week and be dispensed by pharmacies around the Motu. It's important to note that both Paxlovid and other intravenous treatments that we've already been using are not a substitute for vaccination, but they do, of course, provide another important option to help us reduce hospitalisation rates and deaths from COVID-19. Now, if we move on to our tamariki, as of yesterday, 14.4% of our cases were aged 9 or under, and another 17.4% were between 10 and 19. So through this Omicron outbreak, the pattern's been similar. About a third of our cases have been in children and teens. So it's quite an important point for me to hand over to Professor McIntyre, who's going to just update on the latest evidence supporting vaccination in children. Peter, over to you, and thank you again for joining us.
Well, thanks very much, Ashley, and kia ora, everyone. Yes, I've been up personal with COVID, visiting to see my grandchildren in Sydney, all of whom had COVID about a week ago, so I had to decamp somewhere else. But certainly giving me a perspective on the the importance of the vaccine in children. Only my oldest granddaughter had a single dose, and everyone did well, but she probably did best. So I wanted to focus on these three key questions that I think many parents are asking about the Pfizer vaccine for their 5 to 11-year-old Tamariki, and that is, does my child actually need it? How bad a problem is it? Does it work if they have it? And is it safe? And so just moving on to that first question, how severe is it? There's a nice comparison recently published from the US, which gives us a bit of a benchmark comparing hospitalizations for COVID with hospitalizations for influenza and RSV. And of course, we had that RSV surge in New Zealand in the middle of last year in this age group, in the children 5 to 11 years old, in a group of US hospitals. And they found that while there were more flu hospitalizations in total than for RSV and COVID, there is this significant but very uncommon issue of a sort of multi-system inflammation, which can affect, brain, heart, kidneys, etc., in a small minority of kids who get COVID that doesn't occur with flu or RSV. And in fact, in terms of kids getting hospitalized, even though it's uncommon, those inflammatory complication illnesses actually accounted for the same number of hospitalizations as kids who had COVID in hospital, required hospitalization, but didn't have this. And so that's something to really, I guess, remember in terms of thinking about severity for COVID. In the Delta outbreak, there's some, I think, helpful Sydney data with, unfortunately for them, much bigger numbers than we saw in New Zealand. And of about 5,000 children in this age group who were in hospital, in fact, most of them were there for social reasons, not because they were sick from COVID. Only about 1 in 200 were actually in hospital due to COVID, and only 1 in 1,000 or so actually required intensive care. And again, about 1 in 2,000 had this multi-system inflammation. So probably a bit less common in the US, which is good. As elsewhere, and as I think my colleagues in New Zealand have been finding, that children with other health problems are more likely to need hospital care. Importantly, they didn't find any increase in kids with asthma, but kids who had other respiratory problems, which, as we know, unfortunately are much more common in our Maori and Pacific Tamariki, were more at risk of being hospitalized, and also kids who had various neurological problems or problems like Down syndrome. But the other important message was that actually, if you looked at these hospitalizations due to COVID, in fact, most of them were in kids who didn't have other health problems, even though the risks to the kids with health problems were quite a bit higher. And talking to my colleagues over here, they've been saying that as I think has been seen, particularly in Auckland, that Omicron, even though it's less severe, so there's a lower ratio of kids getting hospitalized to cases, because there are just so many more cases, with Omicron, they have been seeing more hospitalizations. So I guess putting all that together, something worth preventing. Now, it gets on to the next important question as well. Okay, this is a problem. If I give my child the vaccine, will it actually help them? And there's some early evidence on this from the US, who of course started before anyone else. And one study looked at about 1,000 children, just otherwise well kids in the community. And in fact, an indication of how Omicron's been sweeping through the US was almost 400 of them actually were cases of Omicron. And they did find that the children who'd had 2 doses had a statistically significantly reduced chance of getting an infection, but it wasn't as high as they had hoped, about a 1/3 reduction, but still worth having. Another study in the US looked at almost 10,000 kids actually turning up at the emergency department, and they found that 2 doses cut back emergency department presentations, more effectively, so by about 50%. There wasn't any data on the really severe cases we've been talking about, the multi-system inflammation or kids who needed ICU, but importantly in adolescents, 12 to 15, there is now a couple of studies showing that the multi-system inflammation is prevented very, very effectively by vaccination. So in summary, yes, it's worth preventing. The complications of Omicron are uncommon, but if we see it as an insurance policy against getting severe disease, and remember that in addition to that, for the individual child, there are benefits to the family, the community, and the school from reductions in infection, and particularly given the fact that this vaccine is available free to all New Zealand children, it does look like an insurance policy worth taking up. So what about safety? Well, again, some slightly bigger numbers in Australia using this text-based system, where had been established a few years ago and has just got started in New Zealand as well, where they ask people, and in this case parents, going to GPs to answer a text about, how's the vaccine gone for them in the last 3 days. And they've had quite a reasonable number of reports in 5 to 11-year-olds for both first and now second doses. And the message is pretty good. I mean, local reactions, not too surprisingly, about 20% of kids, but less common than adults. Fatigue and headache, again, occurring, but less commonly than adults. Muscle or joint pain can be troublesome occasionally. And a few kids, particularly after the second dose, were getting fevers, but really very uncommon. And importantly, less than 1 in 200 children actually needed to go and see a doctor in the 3 days post-vaccination, which may or may not have been related to the vaccine, but that was about half as likely as adults. So again, all the evidence that we can see on routine safety, it's actually looking better in this child age group than it has even in the adolescents, but particularly in adults. After the second dose, there was close to 10% of children who needed to take some time off school, mainly because of symptoms like muscle aches, headache, or fatigue, but it was all very short term. And then the one which I guess people have been concerned about, because we've heard so much about myocarditis, even though it is also rare as a side effect of the Pfizer vaccine, there is an early report from the similar system in the US to CALM in New Zealand, where they just capture all the reports coming in. And after 8 million doses, really reports of myocarditis that have been actually checked are very rare, about 1 in 750,000 kids receiving the vaccine to date. More common after the second dose, as it is in adolescents and adults, and also in boys. But all these cases have been mild, and almost all had resolved by the time this report was given. So something which is probably worth drawing to your attention, I've shown this to a few people in New Zealand, it's been developed by an Australian group, but for parents who have a lot of questions, this link to the decision aid that takes you through point by point may be something that people are interested in looking at. And of course, the other vital thing with the vaccine for the 5 to 11-year-olds is recognising that parents are busy and have trouble getting to appointments. And I'm sure both the district health boards and primary care are looking how to make it easier for parents to actually access the vaccine, which, I think it's clearly beneficial. So thank you. That's all I have to say.
Kia ora, Peter, thanks very much. And we will circulate those key slides, including that URL with where that decision aid is and available for parents. As Peter commented on, we've actually started doing similar surveys of parents via text to what had been done in Australia, and from late January, text messages have been sent to a random selection of parents and guardians of children who have been vaccinated 6 days after their first and now second vaccinations. For the first vaccination, there were 8,300 respondents, and very similar to the Australian data, 18% reported some sort of side effect post-vaccination. For the second dose, the equivalent figure was 24%. Most common were reaction at the injection site, headache and fatigue, all expected and commonly reported side effects that pass quickly. And again, very similar to the Australian data, less than 0.5% for both the first and second dose required had any need to seek medical advice or care. Very reassuring, and we will continue that follow-up survey as well, and we are doing that too for adults, and the data are published on our MedSafe website. Two more things I'd just like to briefly cover. First of all, just to confirm and reiterate our advice about vaccination post-COVID infection. There are a lot of people around the motu now who have had COVID-19, and some of them are still due and or interested in having their booster. We're recommending a wait of 3 months from the date you test positive to getting that COVID vaccination. And this applies after regarding first, second or booster doses for all ages, and it also applies to all COVID-19 vaccines in New Zealand. This wait of 3 months after testing positive can give a better level of protection and an improved immune response to the vaccine. Finally, on to flu vaccination. As we move into winter, we know flu will come back across the border, as will other viruses like RSV. Flu vaccine will be available from tomorrow, the 1st of April, and already around 360,000 doses have been distributed around the country to support the start of that campaign. We have additional stock ordered this year to support the flu vaccination campaign. As usual, that will be at general practice and at pharmacies, and many people will be able to access free vaccination as well through their workplace. Please do avail yourself of that opportunity. There are high rates of COVID infection still in some parts of the country. If you have had COVID-19, it's okay to get your flu vaccination as soon as you've finished your isolation period. No need to wait, and as long as you don't have a fever. And please remember also that even if you've had a COVID-19 vaccine, you still need the flu vaccine, and vice versa. They don't provide any cross protection. So both are going to be important for this winter. Okay, I'll open up now for questions, either for myself or for Peter, who will be able to hear and respond to relevant questions.
Bloomfield, Canterbury is now leading the way in infections, and you touched on this a bit before, but has had far lower hospitalisation rates compared to the main cities and regions. What do you put that down to, not just for Canterbury, but some of those other smaller regions across the country? Yes,
I think it's something we're looking into. One of the things I would say about Canterbury is they're providing a lot of support out to primary care and to aged residential care, including staff. So it may well be that people who would otherwise have needed to be transported to hospital are able to be cared for either in their homes or in aged residential care facilities. The lower hospitalisation rates out in some of our regions is actually a little bit puzzling, and if we think of Tairāwhiti, we were worried because they had a lower vaccination rate perhaps than other parts of the country. Certainly we know that everyone has put a huge effort into ensuring that care in the community program is very focused on the people at highest need, and that they have both the medical and social supports required to keep them at home safely, and that I think is playing quite a major role in preventing people requiring hospitalisation.
What's the missing piece in that puzzle to determine why some regions have lower hospitalisation rates compared to others? Do you think you'll kind of solve that mystery in the near future, or is this something you're just going to have to carry on with?
Well, we'll keep looking at it, and I suspect that the reasons differ across the different regions. But it will be probably based more on soft intelligence from talking with the teams who are working in those areas, rather than us being able to use data to verify exactly why those hospitalisation rates might be lower in some regions other than others.
And once the outbreak has peaked, how does that look for New Zealand 6 months or so down the track in terms of community infections? What could our numbers look like down that track?
Well, we're certainly expecting that there will be a residual baseline level of cases, particularly as we go through into winter. So we've modelled, and that includes my back-of-the-envelope calculations and some more sophisticated modelling, around 3,000 to 5,000 cases a day as we come out of the Omicron peak, and therefore there will be some people infected who will require hospitalisation. And also what we have seen overseas, and we are seeing here, a long tail in that hospitalisation rate. So I'm expecting we will still have several hundred people in hospital through April and into May, and then of course we will have winter coming on, when we know that respiratory viral illnesses like COVID, like RSV, other coughs and colds and influenza, of course, are more common, and that will then lead to more illness out in the community and more people in hospital. So the next 3 to 6 months as we go into winter, we are expecting there will be a significant baseline level of disease in the community.
Dr. Bloomfield, do you wish that we got that medication that's arriving, that's going to be available next week, Paxlovid, sooner, given you've said it can reduce hospitalisations and deaths, and given that we've had 338 people die from COVID-19?
Well, what I would say is Paxlovid and other treatments are in very high demand globally, and Pharmac did an excellent job. Remember, they secured this late last year, and New Zealand, like every other country, has had to wait until it has been available. They've actually been able to bring forward the arrival of this first lot of treatments, and it's of particular value in those people who are at higher risk of hospitalisation. So it's great that we've got it now. The timing was not really within our control, but we are, now we have got it. We've got the systems in place to make sure it is getting to the people who will benefit from it, and it should play an important role, not just through this outbreak, but through winter, in keeping our highest risk people out of hospital, which is great. I mean, very high efficacy, this Paxlovid especially. 5-day course, needs to be started within the first 5 days of someone being symptomatic, but really shown to be very effective at keeping people out of hospital. So it's great we've got it.
Dr. Bloomfield, just given that far fewer people are scanning, what's the value in keeping the COVID Tracer app on your phone? And do you think that Bluetooth is perhaps more important as we progress forward?
Well, of course, the Bluetooth functionality is part of the app, and so that's one good reason to keep it on your phone. I think Andrew Chen did a nice article in the last few days explaining why he thought it was important people keep the app on their phone. It's good to see too, well, that some people maybe are just because we're in the habit are still scanning wherever they go. And the important thing here is we have paused using the app and requiring people to scan, but it may still have value for us. This virus has thrown curveballs our way to date, and there may well be another one coming our way, in which case the app and therefore the ability to scan could play an important role.
We've also heard about a strain called Deltacrop. Have you seen any of these cases here in New Zealand? Is that of any concern?
We haven't seen any so far in New Zealand, and there are sporadic reports of this, particularly in Europe. Some of the whole genome sequencing showing that the different viral strains are sort of combining. But that would only become a variant that might be of interest or of concern if it had a transmission advantage over the strain we know is causing virtually all the infections here and also in most other countries. And even in the last few days in the US, now the majority of their infections here are from this new BA2 subvariant of Omicron. So it'll be interesting to see what happens there, please.
Dr. Bloomfield, I'm referring to the case of the Auckland man who died of COVID this week, and he had rung his city councillor asking for help feeding his family. Do you think it's acceptable that someone dying of COVID is having to be concerned about what their family is going to eat, and what happened to the wraparound care being provided in the community? Is this accessible enough for everyone?
I think it's unfortunate that this person, firstly that that this death resulted from COVID, and I think it's unfortunate the person felt they had to ring their counsellor. What I can say is, and we get daily reporting on this, is that there is very high level of responsiveness to requests for support, social support, and most of those are for food. And all the people who request and need food or other support are having those requests turned around within 24 hours. I'm not sure of the details behind this particular person, but what I can say is that the system has been and is continuing to work really well for people, and so and likewise MSD is responsible for that provision of food. They haven't raised any concerns with me, or I haven't been notified of any concerns particularly around this case.
Dr.
Bloomfield. You spoke last week about your expectations and aspirations around the adult vaccination rollout and how that had been exceeded. Just with the paediatric vaccinations, obviously things a bit slower there. What are you hoping for? Are you frustrated by the speed at the moment, and what are your aspirations for that rollout?
Well, as you might expect, my aspirations remain high. I'll make two comments, and then Peter, this would be something that would be good to get Peter's view on as well. The rates that we're achieving are very similar to what is happening in other places around the world, and actually here quite a bit lower than what we had. Parents were indicating was their intention or to vaccinate before we started. I think it's always good to benchmark your aspiration at what has been achieved in another country. And I was on a call yesterday with my counterparts from a number of Polynesian countries, and the Cooks has achieved 83% coverage for their 5 to 11-year-olds. So I think that's something we can and should aspire to. But perhaps, Peter, you might want to comment on this particular issue of coverage amongst 5 to 11-year-olds.
Well, it's always hard to know, isn't it? But I think we can guarantee that there'll be two major issues. There will be access issues for some parents who just have difficulty, getting their children, particularly with larger families and other, social problems that the family is dealing with, just getting kids to the vaccine centre. And I know some of my Maori colleagues have been very keen to encourage the notion that the whole whānau comes and use that as an opportunity to ensure that the booster rates are as high as they can be in adults as well. So I think that those access issues are incredibly important and something which I know a lot of people are doing a lot of hard thinking about. And then there will be a group of parents who are just not convinced yet, and the sort of 55% rate that we're seeing is consistent with that for parents who have just got on board, taken the message and done it. And then the fact that there might be another 20 or 30% of parents who really have a lot of questions and there are things they're uncertain about. I think the decision aid could be a very useful tool for those parents. But I think we just need to keep pushing the notion, particularly about the safety of the vaccine, because obviously, although COVID is still a problem for children 5 to 11 years of age, it's much less of a problem than it is for older adults. And so that means that obviously parents are going to have a much bigger focus on safety concerns. And I think all the news is really very good on that point. And in fact, it would seem that the vaccine to date is performing much better in terms of those minor but annoying side effects that occur in the first few days than it is in adults. So I think hopefully that once that message gets out, parents will be reassured.
Just talking about those barriers, because this was raised with Minister Hipkins yesterday. Initially, some months ago, he talked about schools and the misinformation and disinformation in schools feeling quite targeted and being somewhat reluctant, I guess, to actually have the paediatric vaccination roll out there as a result. So can you talk through what it is that is actually being done to get these rates up, like specific tools that you're using, specific communication channels you're using, and are you, I guess, sourcing from, you've talked about the 83% rate in Pacific, are you sourcing ideas from other places and how they've done it?
It's a big topic because there's a lot happening, but I'll give you as much response as I can. On the latter point, one of the advantages of the hour and a half I had with my counterparts yesterday was it was an exchange of information. Of course, quite different contexts, but my sense is that we're not facing an issue so much of vaccine hesitancy here. I think parents are reasonably comfortable with the vaccine and we can see what's been possible in the Cooks. But some of them indicated when we first surveyed them, they were going to wait a month or two. And I think they were waiting for that safety data. And we've now got really good safety data from abroad, but also our own New Zealand Aotearoa-based safety data that shows, yes, you may have been waiting, but we can really reassure parents this is a very safe vaccine for children. On the point of the range of initiatives underway, happy to provide more detail, but we've been, over the last few weeks, working with every DHB on a weekly basis on a series of sort of local, tailored, bespoke sprint events to reach out into different communities. And in our our media release today, there's one of them. It's in Manurewa this afternoon that is targeting 5 to 11-year-olds as well as, of course, adults for the booster. So there's been a lot of bespoke initiatives in different regions, and some of those have been school-based, depending on whether the school was willing and the community felt that was a place. So we're certainly taking every opportunity we can to make sure the vaccine is available and accessible.
Because how for us groups, I guess, are you prepared to go? Because we know school holidays are coming up. We know that there's now more mobile vaccination clinics available and on the road. I mean, could we see in the school holidays, for example, in particularly low-rate communities, these vaccination buses literally driving around streets and vaccinating kids?
It's possible, and we will, of course, be guided by what the local providers and communities are suggesting. What I should also emphasise, though, is that by far the most common locations where children are being vaccinated so far has been at pharmacies. Good uptake there, including amongst Māori and Pacific. And so that's been great, but also general practice is still playing an important role. So it will be continuing to make sure all these different places are available for whānau to go and get their kids vaccinated.
When you say that's possible, is that something that's been actively considered? Because presumably going to people's doorstep is about as accessible as you can get.
It is indeed. I'd have to check with my team, but what I can say is that some of these bespoke initiatives that have been done over the last few weeks have been very, very strongly mobile and reaching out into small parts of the community to try and get those vaccination rates up as high as possible. Any other questions?
A couple of points. The case fatality rate for over 90s has been sitting around 7%. Do we know why that's been higher than anticipated?
Well, I'd have to go and have a look at that. One thing I would say is that we've had very high double vaccination and booster vaccination rates for our over 90s, in fact for our over 65s, including in all the ethnic groups, which has been great. But I'd have to have a look and and try and get a sense of why those rates might be higher in over 90s and come back to you on that. There could be a myriad of reasons.
On a similar note, figures show that about 12% of fatalities among over 70s of Omicron that have been in ICU.
Mm-hmm.
Why so few of them in ICU?
So I think as your question is, why is it there are over 70s who are not getting intensive care prior to dying from COVID-19? Well, that's very much because people are receiving the level of care that is appropriate for their age and, of course, if they have other conditions and where they may be. And we know that some of those people, particularly the older people who have been who have died from or with COVID-19, may have had an end-stage illness anyway, and or it was both their and their families' very clear wishes that they didn't want very active intervention, including intensive care.
What's your reaction to the research out today showing New Zealand has the highest rate of melanoma cases and deaths in the world?
Well, it has been and remains an incredibly important issue here in New Zealand, and I think it's one that's been on our radar for some time. But it does reiterate the fact that we've got work to do. I mean, melanoma is a significant cause of early death from cancer in this country, or early death period, but also early deaths from cancer. And we have good evidence now about what can be done to both prevent and identify it early and treat it effectively if it is identified early. So it's a very, very good and clear reminder that it's something we need to keep focused on.
It's predicted to increase by 56% by 2040. What is being done with that good evidence to slow this rate down?
Well, prevention's key there, and we know that UV sun exposure is really important, and there are specific initiatives on that, and I think everybody's aware of the importance of that. A really key reminder here. Likewise, there is ongoing work, and the Cancer Control Agency is playing a leadership role in this around raising awareness about what are the symptoms or what are the signs where a lesion, a mole or something might be causing problems, and having that checked as soon as possible, checked early, and if it proves that it is melanoma, having it treated early, and that's by far is a really good predictor of a good outcome if it's treated early.
Are you comfortable with the rate, with the cost of a mole map?
Well, at the moment, mole maps are one way to help with early diagnosis, but they're not the only way. So I don't have any particular views on the cost of that. I don't actually know what the cost is.
I've got a question from a colleague about mental health. The National Party is saying that 304 counselling sessions have been delivered by the frontline mental health and wellbeing services at tertiary institutes at a cost of $4 million. Is that correct? Do you know that claim?
Well, there was some publicity about this over the last week. One thing to be clear is that is one initiative that is part of a whole suite of initiatives, and that was specifically targeted on counselling sessions in tertiary institutions. So I've seen the figures. What I will say is, of course, that the funding is there to set up a service and to be made available for those students. And of course, the expectation from us will be that the service is delivered.
So the figures are right?
Well, I understand, in fact, this is not new because, in fact, they've been circulated, I think, over the last week or so.
Just finally,
Please.
Is there any update on the investigation into a potential fourth dose of the COVID vaccine for vulnerable people?
Yes, there is an update, and at the back of the room is the Chief Science Advisor, Dr. Ian Town. So I have the advice sitting on my desk, which is really the advice of our technical advisory group on which groups they would recommend that the vaccine or a fourth dose of the vaccine be offered to. And so you would expect, once ministers have seen that advice and made a decision, that there be an announcement, and that's likely to be in the next week or so. Okay, if there are no other questions, I'd like to thank Peter again for joining us from Sydney. I hope you get some time with your mokopuna there while you're across the Tasman, Peter. Really appreciated your insights and expertise, and thank you again, everyone, for coming up. Kia ora.
Goodbye, everyone.